Okay. Well, welcome everybody. Thank you for coming to our third session of looking at QBLISS. Every session I've been getting a lot out of, and I think during this session you're going to see we're going to give you a lot of information because we have Dr. Kim from Korea, and I'll talk a little bit more about him, but he's a wealth of knowledge, especially in this area. He's kind of an expert in the QLF and the development of this. So I'll talk more about it. I don't want to take up too much time, but Dr. Kim, why don't you start? And then thank you very much for being here.
Okay, thank you, Mike. Good morning and good afternoon, everybody. I would like to talk about the early dental caries detection with the QBLISS. In my presentation, as I want to introduce the why is the early caries is important, and also I want to explain about some progression mechanism of the early dental caries. Before starting my presentation, I would like to start this slide: fire stages, warning sign, and countermeasures. Fire progression begins with the smoke, then the development of small fire. Finally, is a big fire. While the fire trucks must be dispatched to extinguish the large fire, sprinkler can be sufficient for the small fire. Even more crucial is the early detection of warning sign of the using smoke detectors. I think the progression of oral disease is similar to the progression of fire. For final stages is maybe dental implants is essential for rehabilitation. Before tooth extraction, dental caries can be treated with restorative treatment. Prior to that, we also can remineralize by fluoride for the white spot lesion, such as the early caries lesion. But the most important thing is the early detection of the biofilm. So that's why we are really focused on the QBLISS system. Also, we have to understand the progression of the developing caries process. Traditionally, dentistry has classified this caries progression spectrum into two stages based on the presence or absence of cavity. However, a clinically identifiable or intermediate stage exists between normal and cavitated lesion. This is intermediate stages can be called as incipient caries or early caries. Incipient caries maintain the continuity of the enamel surface, but appears as a white spot due to some difference in the refractive index. In contrast, there's advanced caries is a kind of the disrupt of the continuity of the enamel surface, creating cavity similar to the sinkhole. Progression of the dental caries is similar to some formation of the sinkhole. Typically, we only detected the presence of the sinkhole at the final stages when the ground surface has clearly collapsed. However, sinkholes have a precursory process that, while invisible to the naked eye, is clearly occurring in the underground. This is a very similar situation to the early dental caries. To understand the progression of the dental caries, we must understand the microstructural characteristic of enamel. First, enamel is not a completely homogeneous structure like glass, but rather than an aggregate of the microcrystal. Especially, enamel is formed when the proteins secreted by ameloblast are covered into the crystalline structure called hydroxyapatite. Therefore, when observing enamel under the electron microscope, we can observe this unique keyhole-like structure. The key point here is the presence of the intact microchannels between the enamel crystals. So microchannel within the enamel serve as the passageway for organic acid, bacteria, and minerals. This is a bit similar to the sinkhole progression. Generally, it is difficult to understand that why incipient caries involve the mineral loss from just beneath the surface, while the enamel surface layer remain intact. Therefore, I will use the analog of the alcohol lamp to explain this phenomenon. When you light the wick of the alcohol lamp, the flame doesn't travel through the wick, but only continues to burn to the outside. This phenomenon occurs because of the alcohol is drawn up into the wick. In other words, the fire can be light to the biofilm and the wick to the microchannel of the enamel and the alcohol to minerals. Now we understand the microchannel play a crucial role in the caries process. So how can we identify the microchannel within the enamel? In this case, we can use the QBLISS. Now also we can understand that there are two kinds of different mechanisms to detect the biofluorescence by QBLISS system. First is the tooth fluorescence. Second is the bacteria fluorescence. So especially tooth fluorescence is very unique. So they can easily detect that some microchannel in the enamel structure by tooth fluorescence loss. So we can also measure this amount by delta F value. Also, bacteria can easily penetrate the microchannel beneath the enamel, so we can detect the radiofluorescence from the early caries lesion. This is very important. Orthodontic patients is prone to the contact caries, so we can easily detect the radiofluorescence from around the bracket. After removing the bracket, we can detect the white spot and the early caries region. So we want to know the real lesion depths of the white spot. According to our previous study, we have this kind of a simple in vitro experiment. We collected some human extracted teeth with white spot lesion. We take the image by QLF, then calculated the delta F value. It means that tooth biofluorescence loss. And also, we cross-cut the whole of the teeth. That we measure the real lesion depths by polarized light microscope. We make this plot. You can see the correlation coefficient R is almost over 0.94. It's a completely linear relationship. It means that we don't need to cut the tooth. If you want to know some lesion depths of the early caries, we just take the imagery by Curie, then analyzed by delta F. That's enough. This is an additional sample. This is the a bit advanced caries. So you can also detect the radiofluorescence in the proximal area. We cross the cut. You can see that some radiofluorescence from bacteria penetrated not only enamel structure but also dentin structure together. It means the bacteria can penetrate the microchannel. In this clinical situation, we cannot easily say it's a caries or not. But in the QBLISS system, you can see that some faint red color appear. Then X-ray also showed some proximal lesion. So we remove the surface, we can definitely find some deep caries lesion inside. It means the QBLISS system can not only detect the early caries, but also detect some advanced caries together. So today, I would like to introduce 3 papers by published our research team. First paper is the we focused on the proximal caries detection. QLF can produce some delta F and the delta R parameter. We want to know that this parameter is useful to detect the proximal caries. However, this delta F and delta R is very useful to the clinical research field, but they are difficult to directly apply to the clinical setting. So, therefore, my research team developed the index that can easily assess the severity of the dental caries using biofluorescence in clinical setting. First, we developed the QS proximal index, which easily differentiated the proximal caries by fluorescence from 0 to 3. We compared this index with the traditional caries assessment method, such as the visual scoring and radiographic scoring together. First, we compared the research parameters such as delta F, delta R with the traditional radiographic assessment method. The result showed high validity with both sensitivity and specificity exceeding 0.8. The QS proximal index developed for clinician was compared with a traditional visual inspection and radiographic example, and showed a high validity with both sensitivity and specificity exceeding 0.8. This is our first paper. Next, second, so we also developed a new biofluorescence index that allow clinicians to easily assess the occlusal caries. This new clinical index also consists of a scoring system ranging from 0 to 3. We examined the delta F and the delta R value for each score with QS occlusal index, confirming the clear distinction. QS occlusal system developed for clinician was compared with a traditional visual inspection, such as the ICDAS, and showed a high validity with both sensitivity and specificity exceeding 0.9. These two papers focused on the permanent tooth. Two previous studies is the only focused on the permanent teeth. However, deciduous teeth have the distinct anatomical characteristic from permanent teeth. Therefore, this study, third study, applied the delta F, delta R value, also QS index for children's deciduous teeth. According to this research, delta F, delta R, and the QS index showed a high validity with the AUROC over 0.9. Therefore, the QBLISS can be effectively applied to some diagnosis of various dental caries of primary teeth as well as permanent teeth. Scientific evidence exists in hierarchy. The three papers I previously introduced were a randomized controlled clinical trial involving human subject. However, there is a third research method called systematic review and meta-analysis that select only the best paper from among the numerous published papers after rigorous quality assessment and summarize the result. Finally, I would like to introduce the study that evaluated QLF using this methodology. This systematic review and meta-analysis paper was selected from the total 481 papers published with the keyword of the QLF through a rigorous quality assessment. Ultimately, we selected 17 papers among them. Quality assessment of the 17 selected papers revealed that were excellent papers with a low risk of bias. QLF showed a high sensitivity and specificity for both occlusal and proximal caries together, and QLF was particularly effective in detecting early caries by this research. In 2021, Korean government recognized this technology as an official caries diagnosis technology and included in the health insurance system in Korea. In the first slide, I showed this diagram of the progression of the fire. If we compare this stage of progression of dental caries, smoke can be likened to the biofilm, small fire to early caries, and huge fire to advanced caries. Our research showed that QBLISS using QLF technology can detect diagnose all stages of dental caries development. This technology was particularly effective in the detecting early caries, which can be easily missed with a visual inspection. I hope that this technology will be widely used in clinical setting in the future to effectively prevent advanced caries that cause pain. Thank you for listening.
Yeah, thank you very much. That was amazing. So we'll keep going with the presentation, and then we'll come back to the Q&A with Dr. Kim, because yeah, that was great. Learned a lot in the short period of time. All right, we're gonna try to do a screen share again, see if I can get this working. Yeah. Let me get this going, and then we'll. No, that was very good. Thank you. All right. All right, I think you can see the slides, right? Okay. So I just wanted to thank Dr. Kim for, yeah, that was a great presentation, because I think for at least, I'm in the United States. And so for me, this technology is fairly new. We've had different kinds of light technology where we could detect early stages of disease. But this early stage of looking at biofilm and today looking at the presentation, looking at decay, I think it's pretty amazing. And it's really, well, it really excites me for what we can do for our patients. So what we're doing today is we're bringing together kind of an academic presentation. And what I want to do is I want to talk a little bit more about the clinical application and how it works in our office. Dr. Kim, that was fantastic. I just want to point out that, you are a professor of preventive dentistry at Yonsei University, and we had the privilege of touring the university. It's a very nice university, very modern, and I was very impressed. You were also recognized as a leading academic, the field of quantitative light-induced fluorescence, which we call QLF. And you've done, as you showed, extensive peer-reviewed research, kind of advancing this fluorescence-based caries detection. And I think the risk assessment, as you and I were talking about, can really do great things in the field of preventive dentistry. And so what we hope that this session will do is it's bringing together, how we can incorporate visual diagnostics in this QLF-based biofluorescence to detect caries changes earlier. And what I want to show you now is how we can use it for clinical communication. Because one of the things is we've had some users try QBLISS and they compare it to like a disclosing agent. But to me, it's totally different. And I think that lack of appreciation of what we can do with this technology, that's why we do these sessions. So when we were out in August, we had the privilege of going out and meeting Dr. Kim and Dr. Yoon and Dr. Albert and being trained on how to use the systems properly. I was very impressed. Again, this is in the dental school, in the lobby of the dental school. It's an expansive dental school, and we had a chance to meet a lot of the professors there, and they were just top notch, just very good. So we really appreciated being there. And this is Dr. Kim. You're giving me my certificate of completion of my training, and yeah, you're a smart looking guy, and it was a privilege to be out there with you. So what I want to do is I just want to go through the communication part, because I'm not in the academic research anymore. I'm more just a clinician, and that's kind of my perspective. What I really like about using the system is, one, we do have the early detection, but because of that early detection, we have the ability to communicate better with our patients. And everybody wants to, catch things earlier, but you have to remember, for our patients to understand the disease that we're trying to show isn't always easy. So here's a patient that came in. She was young, she's a young teenager, and you look between the central and the lateral here, and you don't see a whole lot. Well, even I didn't see a lot of bad in this. And if we look at the radiograph, now we can see that there's very deep decay in the lateral. There's decay in the central incisor. But if you told the mother of this patient, we might even have to do a root canal, and the mother's looking at the teeth, because, mom can't necessarily read a radiograph. That's very hard to understand. My daughter doesn't have a lot of pain right now. Why are you saying we have to do a root canal? And so what we were able to do is we do have AI technology when we look at our radiographs. And so we can color that fuchsia area in and show the patients, well, where this pink color is, that's where there's decay. You can't see it, but radiographically, we can. And then we can add all the other anatomy in there with our AI. The purple right there is the pulp, the nerve, and the blood vessels that go into the tooth. The green is kind of the insulation layer. We call that the dentin. And then you have the white tooth colored part of the tooth. That's the hard outer shell. Now, this decay has penetrated through that hard outer shell, as Dr. Kim was mentioning. We've gone through the enamel. So next thing we do, and we've talked about this in other sessions, is, an intraoral photo with a radiograph doesn't really tell the picture to the patient. Maybe it does to us, but not to the patient. So now we have to tell this mother that, okay, we're going to use this camera, and if you see red, red is bad. So now when we light this up and I'm shining the light at this area, you can start to see the red glow that's showing up almost throughout that lateral. And now as I bring that picture up, you can see that that lateral incisor almost glows red. So the more incisal 2/3 is red, and the distal part of that right central also is red. So now we tell the mother, as we're looking at this image using the QBLISS, that that red is bad. And what I want you to look at is how much of that tooth is glowing red. That is the area that when we go into this tooth and we start to clean out what may appear to be a small little hole that you see from the outside, but on the tongue side, it's much deeper. But as we start to clean this hole out, that's why I'm telling you this tooth may need a root canal. Like, we do not want to do a root canal if we don't need to. But what's happening now is our patient doesn't have to read a radiograph. The color begins to resonate with the patient, because all we do is we tell the patient, red is bad. So if you see a lot of red, that's not a good sign. What this QBLISS system and technology is doing is it's showing us tomorrow's potential problem today. And that's why if we had caught this earlier, it could have have been prevented, because we would have seen the biofilm in the interproximal area between that central incisor and the lateral incisor, and we could have told the patient, we need to keep this area cleaner. Or if we started to see some demineralization before, when it was incipient, not cavitated, maybe we could have done some kind of remineralization procedure to try to save this. But now what happens is when the patient sees that tooth glow with that much red, we don't have to convince them anymore, because now they know red is bad, and most of that tooth is glowing red. And so now they ask us, okay, how do we fix that? And that's, I think, the power of what we're able to do is this technology, because it makes problems more visible. So our patients are more apt to say yes to the care that they need. And some of the research that AIOBIO has done just shows that the majority of users, when they were surveyed, found that they would save more than 5 minutes in talking to their patients. And time in a busy dental practice is precious, and it has value. And so the more time that we can save, the better it is for all of us. And if the patient sees all that red and they're convinced, and they can see how much bad is in that tooth, and they just ask us, instead of us having to explain that, what do I do? That's powerful, because not only have we saved time, but the patients learn to trust us before we do the procedure. This is from the lingual side, the tongue side, and you can see that when we illuminate this, again, even on the lingual side, it's glowing very red. So red is bad. This is nice because with the Q pen, we can actually capture an intro photo that's more than intro photo, because we have the biofluorescence. So before we started this procedure, we were able to explain to the patient, one, that there's a lot more decay in this area than you can see from the outside. Two, that there is a potential of having to do a root canal because there is so much decay. And as we began to take this out, you can see we're starting to get a small pulp exposure, where even before with our AI, the fuchsia areas that were showing where the cavitated lesions were, they were not close to the purple areas where the pulp and the nerves were. But we got in there and we did not do the root canal on the lateral incisor. What we did is we used bioactive adhesives that would soak into the dental tubules, helping to create more hydroxyapatite and helping the nerve heal and shield itself. Then over the top of that, we use a bioactive composite that creates that hydroxyapatite in a very alkaline environment so that that tooth can continue to heal. So we did this a while ago, and the patient has had no issues. Again, fairly young tooth, so the pulp is healthy, and I think in this case, this tooth is going to recover very well. But we got that decay out. We had informed the mother of how deep it was before we got in there. She could see the glow, and after that, we did not have to convince the parent why we needed to do this. She knew. So again, when we're in that situation where from the outside, the patient's looking into their child's mouth and they see maybe a little bit of a groove in that tooth, where there's some early decay, and we tell the patient, well, we may have to do a root canal, that's a shock to them. But in this case, because of the QBLISS equipment, because we could explain that the red color is the bad areas of the tooth and how extensive that was, the mother and the patient, they didn't question us. When we got done with the procedure, they thanked us because they really understood what we were trying to do, and they really appreciated that we were able to treat that patient without having to do the root canal. So we're able to use the light to detect things, in this case, not so early. It would have been nice if we could have done it a little bit earlier, but we're able to show that biofluorescence to the patient so they understood the situation, and then we were able to treat. So I think one of the things that that I want to discuss and really encourage everybody to do is share this information with your colleagues, because what we're doing is we're building a community of clinicians that are trying to do the very best for their patients with the QBLISS system. And I really think that we can do the very best for our patients when we use this technology. It's proven, there's research that backs it, and it is not the equivalent of a disclosing solution. It really is a much greater system. And we'll be talking about that in future programs coming up, because even the camera, we use that to help us with our aesthetic cases. We use the intraoral camera, the pen, to show the patients all the details, like the photos that we just showed you of the teeth. And then everything else with the system just comes together like no other system that I know. So we're going to go back, and Dr. Kim, maybe there's some questions that we can ask. I know I have some questions. I just want to, I'll just show this slide and then I'll stop sharing. But again, we want to thank Dr. Kim for being here. I want to thank you, the viewer, for being here and joining us. And something to think about, at least in the United States, we're all trying to differentiate our practices. We're trying to show our patients that we care about them, and we are trying to do the very best we can for them. We're not trying to over-treat, but we're trying to provide the best treatment for them. And I think QBLISS, using this technology, makes you visibly different from other practices. And I think, visibly, where it's kind of a play of words, but if we can communicate with our patients better, they will value what services we offer much more. So I'm going to stop sharing, and we'll go back and we will do a little bit of Q&A. So I'm going to close this up. So, one of the questions, and I don't know if there's any questions that have come in from people watching, but Dr. Kim, I had a question. Now that we're with the grading system that you had, I really like that, because as we were talking about, I think it's, in order to communicate what we're seeing, it's nice to have a grading system, just like anything else. Is that system, are you able to use the MCA with that, or is it more visual?
Yeah, that's a very good point. Is that until now, so I only focused on the research aspect. So in that case, I mainly use the delta F and the delta R, only two parameters. But now, as the AIOBIO developed this very useful color analysis automatically system by MCA, it's a very useful and promising. And now, we are ongoing the project to compare the validity between the conventional parameter and the MCA parameter. After that, we will publish some paper about that. I think we make a more easy and simple example to show to not only clinician but also the patient. That's why they can easily understand the meaning of these things.
Yeah, I think that's the exciting part, because whenever we have something that's visual, there's a little bit of subjectivity to that. But when we can use the MCA and the AI technology that's being placed into the QBLISS system, it quantifies things, and then we can track it over time, right? See if we're using a remineralization product, we can see if that incipient lesion heals itself basically as we try to remineralize that. So I think that's going to be very exciting.
Also, today I introduced the two clinically applicable index, such as the QS proximal and the QS occlusal index. The reason I developed this, because in clinical situation, is the delta F, delta R analyzing process is too complex. It's time consuming. So that's why I developed this index. It's a bit similar to the gingival index and the plaque index. So I think that we can combine together this index to some AI system. In that case, we can easily suggest some final result, to the more very simple answer to the dentist and the patient together.
Yeah, no, I think that's very exciting. I really like today watching what you're describing, how the research that you're doing, showing the effectiveness of using this technology. I really enjoyed that. But I will tell you, just as a fellow educator, the way that you use the metaphors and you draw everything together, I really enjoy that, because even though you have a short amount of time, the information you presented, it sticks in my brain. So yeah, I want to say thank you very much.
Okay.
And I know we have Dr. Yoon. Dr. Yoon, did you want to add a little bit? Maybe you have the greater vision.
마이크가 꺼져 있네요.
Today lecture is perfect. So actually we have some question. We should resolve actually that kind of question. So many users sometimes ask us to Baek-Il or to me. Okay, red is actually we know the meaning of red, and then how deep remove the actually caries. Okay, so remove the caries, but actually still there is the little bit the red area, right? And then actually we should remove more or not. When we remove more and then actually connect to the root canal treatment, right? But patient don't have any symptom. Yeah, so at time you mentioned the bioactive resin filling, right? So we need more research about actually that kind of real clinical situation. Even we are using the QA technology, but actually in the real clinical situation, what is actually the proper protocol? Yeah. So there is a reason why your experience in the United States is very important.
Yeah, in the United States, the AAE, the American Academy of Endodontists, they kind of accepted that there can be vital pulp therapies done. So I think that is starting to pick up. If we have a small pulp exposure on a fairly healthy pulp, we don't have to do a root canal on every one, and sometimes they will heal up. So that's a very good point. Since I have both of you here, the other question I had is, as I was listening to Dr. Kim, by the color and the location of the biofluorescence, you've correlated that to the depth of the lesion in the tooth, right? Is that something that MCA is going to be able to do? So if we get a certain reading, we'll know how deep into the enamel a lesion goes?
Yeah, it might be possible.
Might be possible.
Yes, because as the previous research only used the delta F by tooth fluorescence, but we need to combine together the radiofluorescence together. So I think that sometimes delta F and some delta R as combining is the very more they can give the more useful information. So I believe that we can develop the more accurate prediction model using MCA on the AI in the future.
Yeah, no, that's very exciting. I know Dr. Yoon will never sleep again until he solves all this. And AI. Yeah. I know the team's working very hard on this, and there's always constant improvements being made. And that's why it's so nice to have both of you on these types of programs to share with us what all the new innovations and all the new developments, because I know things are changing very fast. You know, from the time we were there, even last summer, and like those photos I showed, I know there's been a lot of progress made. So, you know, we really appreciate that. And I think, again, that's one of the exciting things about this technology is that it's constantly being improved. So what you see today, the use of the equipment and the color and the interpretations, that's where we are today. But you've got Dr. Kim, who is doing continual research at the university, and Dr. Yoon, who's constantly developing and improving this equipment. So, I feel like we're just touching the beginning of what this technology is potentially going to be able to, be beneficial with us. And I think that's the exciting part. So I want to thank you both.
Yeah. Thank you, Mike.
Thank you.
Yeah. Thank you. Well, I know it's a quick half hour, but that's the end of this program. And I really want to thank everybody once again for joining the program. Share this information with your colleagues, because I think everybody that attends and watches these programs, you truly do want the best for your patients. So let's use this technology to help us. All right. Thank you very much.
Thank you.
Yeah.
Thank
Bye-bye.
you. Bye-bye.